Today I will talk about quality management. This is part of my series of lectures on blood banking. This is my lecture outline. I will discuss internal quality control of reagents and solutions, internal quality control of blood components, equipment calibration and management, internal quality control of test for transmission transmitted infections, document control, external quality assurance, Hemovigilance, hospital transfusion committee, internal audit, management review meeting, and quality indicators. So this lecture, unlike my all other lectures, will be little longer. These are the steps of transfusion. Some of them are inside and some are outside the blood bank. First of all, there is decision to transfuse the patient with blood or blood component. Then requisition is sent to blood bank along with blood samples of patient. The request is processed by blood bank according to the standard operating procedures. Then the component or blood is collected from the blood bank and maintaining the cold chain is transferred to clinical area. Then there are pre-transfusion checks, then actual transfusion and monitoring of transfusion, then recording of transfusion, then audits and performance improvement. So these are some of the steps of transfusion. Good manufacturing practice, quality control, and audit program all are closely linked together. These are the requirements of quality management system. These are very similar to that of a clinical laboratory. So its components are organization and management, accommodation and environment, personnel, equipment, external services, supplies and reagent, process control, identification of deviations and adverse effects, performance improvement, document control, records, internal audit and management review. Blood centers shall maintain quality assurance to ensure that the products produced are fit for their purpose, they are free from infection, and they contain required bioactive substance to provide clinical benefit. Internal and external quality control shall be carried out to ensure that tests performed are as per the protocol and the results obtained are reliable and reproducible. And the process is documented. Now let us see what is internal quality control of reagents and solutions. This is the recommended frequency of testing for reagent solutions. Either they are done each day or before each run. So now let us see the internal quality control for bovine serum albumin. The reagent shall be free of the non-specific agglutinants and shall not react with saline suspension of A, B and O cells. Enzyme reagents, these are the enzymes which can be used in blood bank for detection of incomplete antibodies. And enzyme shall be aliquoted and stored in frozen state. Only required amount for the daily use shall be thawed. The unused enzyme remaining at the end of each day shall be discarded. Normal saline buffered solution, these solutions shall be checked daily for pH between 6.7 to 7.2. And there should be absence of hemolysis with random A, B and O cells. Then about reagent red blood cells, there shall be a pool of 3 individual cells for each group. Cells shall be prepared daily and shall be free of hemolysis. Each batch of reagent cell for serum grouping prepared shall be tested to confirm specificity. Then red cell panel. These are either commercially available or prepared in-house. The red cells shall be stored frozen or at 4 degrees centigrade. The red cells stored for more than 48 hours at 4 degrees centigrade shall be checked for reactivity of at least one weak reactive antigen by saline and indirect antiglobulin test. So these are the standards for quality standards for the reagent red cells, and this is for normal saline. Then about ABO and NTD reagents, a vial of every new batch or lot shall be checked for titer. All anti-sera and other reagents used for serological work in blood banks shall be checked daily for specificity and avidity. All reagents showing turbidity and discoloration should be discarded. Manufacturer package insert shall specify titers, avidity and all the relevant information. Methods followed shall be as per manufacturer's instructions. At any given time, there shall be two different batches of anti-D reagent available either from two different manufacturers or two different batches from the same manufacturer. These are the standards for anti-A anti-sera. These are for anti-B anti-sera. You can pause the video and record these. This is for anti-AB anti-sera. This is for anti-D anti-sera. Then about anti-human globulin reagent, one vial from every new batch or lot shall be checked for its specificity and reactivity using incomplete anti-RH IgG coated cells. Each test shall include positive and negative control. Non-sensitized A, B, O cells shall be checked to rule out non-specific reactions. And all negative anti-human globulin test or Coombs test shall be confirmed by addition of IgG coated cells in the test. IgG coated cells shall give positive agglutination. These are the standard for anti-human globulin. Then internal quality control of blood components. Blood components should have adequate medicinal value. They should be free from bacterial infection and of course free from transfusion transmitted infections. The frequency of quality check should be 1% of all units or 4 per month, whichever is more. So this is summary of medicinal value. Whole blood should have hematocrit more than 30%. By leukocyte depletion, we mean less than 5 into 10 raised to the power 6 leukocytes per unit. Packed cells should have hematocrit more than 65 to 70%. Random donor platelet concentrate should have platelets more than 3.5 into 10 raised to the power 10 per unit of 350 ml. And single donor platelet or apheresis platelet should have more than 3 into 10 raised to the power 11 platelets per unit. And FFP should contain stable coagulation factors as assessed by PT and APTT tests. So this is a summary of medicinal value. And these are the standards for blood component. This is for red cell. This is for red cell for intrauterine transfusion. This is red cell for exchange transfusion. These are platelets. These are also for platelets. Then apheresis platelets. Apheresis platelets for pediatrics. Fresh frozen plasma, cryoprecipitate, single donor plasma, granulocyte concentrate, granulocyte apheresis. So this I have reproduced the requirements for storage, transport, expiration of blood and blood components. The whole blood should be stored at 4 degrees centigrade plus minus 2 degrees centigrade, and that in CPD have a shelf life of 21 days, that in CPDA have a shelf life of 35 days. The irradiated whole blood have a shelf life of 28 days. The packed red cells or red blood cells should be stored at 4 degrees centigrade plus minus 2 degrees centigrade, and the shelf life is very similar to the whole blood, except for when additive solution is added like sagum, the shelf life become 42 days. Platelets should be stored at 22 degrees centigrade plus minus 2 degrees centigrade with continuous gentle agitation. And shelf life is 5 days. And if it is without agitation, it is just 24 hours. Fresh frozen plasma stored at minus 30 degrees centigrade or lower have a shelf life of 12 months. If it is thawed, it has a shelf life of 24 hours. Then let us see about internal quality control of equipment, that is calibration and maintenance of equipments. All equipment should be under annual maintenance contract or comprehensive maintenance contract. Equipments must be periodically calibrated as per schedule. I'll tell you later. The equipments must be numbered and they should be given unique ID. This is apart from serial number given by manufacturer. They should be placed properly to facilitate cleaning and maintenance and according to the workflow. They should be supplied by suitable and stabilized electric voltage, and they should be maintained daily. Only authorized personnel should operate all equipments. Up-to-date instructions on the use and maintenance of the equipment should be readily available to the personnel. The program for calibration of equipment should be designed and operated so as to ensure that calibrations are traceable to international system of units. In case of any equipment show out of range value, necessary action shall be taken before putting equipment back in service. The blood center should have a system for investigating and follow-up of equipment malfunction, failure or adverse events while working. The blood center shall have a procedure for replacement or repairing of defective equipment. Whenever equipment is found to be defective, it shall be taken out of service, clearly labeled and appropriately stored until it has been repaired and shown to be calibrated to meet specified acceptance criteria. Each equipment should have a label on it, and the content of the label are as follows: unique identification of the equipment, manufacturer's name, type, identification, serial number, manufacturer's or service provider's contact person name and contact details, date of receiving of equipment and date of putting into service, current location of equipment, condition, whether it is new, used or reconditioned, calibration status and due date of calibration. So this should be labeled on the equipment itself. These are the schedule for equipment calibration. Now, internal quality control for test for transfusion transmitted infections. Use of enzyme linked immunosorbent assay or rapid test is recommended using kits approved by CDSCO for India and similar organization in other countries. Any other recent approved technology with same or increased sensitivity may be used, and the test shall be performed as per the instructions of the manufacturer. Positive and negative control shall be run with every batch. Now a bit about rapid tests. Rapid test approved by CDSCO for India shall be used for screening in emergency, in rural area, or any center collecting small volumes, or where power and requirement maintenance is a problem. So only in this scenario, the rapid test should be used. Otherwise, at least ELISA is used or nucleic acid testing is used. For syphilis, VDRL or TPHA or RPR method can be used as per manufacturer's instructions, and positive and negative control must be included with every batch. We should prepare LJ chart for ELISA based test, and for LJ chart, first E ratio is calculated. E ratio is equal to OD of quality control sample divided by cutoff value, and the E ratios are then plotted on LJ chart. Then mean, standard deviation and coefficient of variance are calculated. Then let us see a brief about document control. Blood center shall have a list of documents in various formats. There shall be an SOP on how to manage documents, duration of shelf life, and method of archiving and retrieving documents. The blood center shall identify documents that are to be controlled and authorized for use by responsible personnel. Issues pertaining to the electronic data. The electronic data should be regularly backed up, and there are security issues related to data. Then the data should have restricted access, controlled and authorized access. So this is about data in electronic form. Then about retention of record, hard copies of all records should be preserved for 5 years as required by regulatory requirements. However, records related to plasma fractionation shall be preserved for 10 years. These are some of list of the documents in a blood bank. These are the registers related to donor information, then a master record register. Then these are the registers related to blood and component issue. These are the registers related to laboratory work. Then registers related to component and apheresis, registered of outside services. Then registers of blood and component discarded. Then registers related to blood stock. Then register related to transfusion transmitted infections. Then register related to quality control. Registers related to reception. Register related to counseling activities. Register related to item stock and inventory. Then registers related to general management. Then a bit about external quality assurance. Internal quality control should be complemented by regular external quality assurance by participation in proficiency testing program. External quality assurance monitor these aspects of laboratory or a blood bank, whether samples are handled correctly, whether assays are performed accurately and efficiently, whether results are recorded appropriately. So these aspects are controlled by external quality assurance. The blood bank shall monitor the results of EQA program and participate in implementation of corrective action when control criteria are not fulfilled. When there is no formal PT program available, then blood bank can participate in a suitable inter-laboratory or inter-blood bank comparison method. The blood bank shall document records and expeditiously act upon results from this comparison in EQA. Problems and deficiencies identified shall be acted upon and record of action retained. Then a bit about hemovigilance. I have a full 3 lectures on hemovigilance. Hemovigilance is similar to pharmacovigilance, and there is organization both international level and national level. Then there are 2 divisions in hemovigilance. One is the adverse transfusion reactions. Then the other is adverse donors reactions. So if there are immediate transfusion reactions, then transfusion shall be discontinued immediately, and the label is checked for any clerical mistake. Patient's blood sample are collected, and they are tested in blood bank for evidence of hemolysis. A direct antiglobulin test shall be done on post-transfusion specimen and on pre-reaction specimen for comparison. In addition to these, the ABO and RS type should be again done on pre and post-reaction blood samples, and test for unexpected antibody should be done. Post-transfusion urine should be examined for hemoglobin or its metabolites. Serum bilirubin can be measured after 5 to 7 hours of reaction, and a sample should be sent for bacterial culture. If investigations are suggestive of a hemolytic reaction or bacterial contamination, patient's physician shall be informed immediately. Then a bit about delayed transfusion reactions. So delayed transfusion reactions include transfusion transmitted infections, graft versus host disease, or purpura. So with regard to transfusion transmitted infections, appropriate tests shall be done to detect the cause of delayed reaction. A record shall be maintained in patient's medical file. Reported cases of suspected transfusion transmitted disease shall be evaluated. If confirmed, the involved blood unit must be identified in the report, Attempt shall be made to recall the donor for retesting and counseling. Other recipients who received components from the suspected blood unit shall also be investigated. And the remaining components, if left over in blood bank, shall be discarded. Then the transfusion reactions after investigation should be discussed in hospital transfusion committee, and it should also be reported in National Hemovigilance portal. These two are important. And this is about reporting of transfusion transmitted, this is about reporting of transfusion reactions. Then hospital transfusion committees. These are also known as blood management committee, blood transfusion committee, hospital transfusion committee. Hospital transfusion committee plays a crucial role in the implementation of national guidelines on clinical use of blood. The Hospital Transfusion Committee is responsible for ensuring safe transfusion practice and implementation of patient blood management or PBM initiative. This is the suggested composition of the Hospital Transfusion Committee. I have a separate lecture on Hospital Transfusion Committee. The committee should have an agreed terms of reference which should be reviewed at set intervals. Membership may also need to be reviewed as there are changes in staff. Ideally, the committee meets quarterly. However, some hospital transfusion committee meet more frequently in larger organizations. Then a little bit about internal audit. So management review and internal audit of all elements of system, both managerial and technical, shall be conducted at regular intervals. Internal audit should be formally planned and should be defined and documented, and personnel shall not audit their own activities. When deficiency or opportunities of improvement are noted, the blood bank shall undertake appropriate corrective and or preventive actions, which shall be documented. The main elements of the quality system should normally be subject to internal audit, and the frequency should be every 12 months. This is about corrective action. The procedure for corrective action shall include a process for investigation to determine root cause of problem, and the corrective action shall be appropriate to the magnitude of the problem. The blood bank shall document and implement any change required after investigation. The blood bank shall monitor the result of any corrective action taken. All corrective actions taken shall be documented and recorded with root cause analysis and shall be submitted to management review meeting. I'll talk about management review meeting a little while later. Preventive action is a proactive process of identifying opportunities for improvement to reduce the likelihood of occurrence of non-conformities. So now about management review meetings. Blood bank management shall review the blood bank quality management system and all of its medical services. The result of review shall be incorporated into a plan that include goals, objectives, and action plans. Documentation of internal audit and management review. The result of internal audit shall be submitted to blood bank management for review with proper documentation including follow-up corrective action, as I have just described. Findings and the actions that arise from management review shall be recorded, and blood bank shall be informed of these findings and the decisions made as a result of the review. Blood bank management shall ensure the arising action are discharged within an appropriate and agreed upon time frame. A typical period of conducting management review meeting is every 12 months. And finally, a little bit about quality indicators. So these are quality indicators related to transfusion transmitted infections. This is the percentage of TTI. This is the percentage of TTI outliers. And this is the quality indicator of wastage of blood and blood components. This is the turnaround time indicator. Then this is the percentage of component issued. This is the component QC failures. This is adverse transfusion reaction percentage. This is adverse donor reaction percentage. This is donor deferral rate, and then this is delay in transfusion beyond 30 minutes after issue. So these are some of the quality indicators, and this is all about quality control in blood bank. Thank you very much.